this past year, we became involved with the sepsis protocol from Lutheran Medical Center and then adapted it here because we continue to see a high rate of sepsis being the diagnosis code for admission into the hospital.
The CNA is at the bedside most often, so they would identify maybe any change in status, weakness, lethargy of the resident. They would notify the nurse in charge and they would start their assessment. They would do a head-to-toe assessment and as well as take vital signs. If they notice any change in vital signs, especially a fever, 101.5 or above, they would let the physician on call know and they would initiate the protocol. The physicians would place the orders such as blood cultures, chest x-ray, rule out urinalysis, and start the antibiotics if necessary. So the CNA's role is very important in identifying the initial signs and symptoms, which we use Interact tools for, such as the stop and watch, as well as sometimes we have someone like housekeeping who would know the residents very well and know that they were not behaving the way they normally do, and they could also identify with our Interact tools any changes. That way we would initiate the sepsis protocol.
Okay, inside every sepsis kit there are 2 sodium chloride flushes that's used to flush the IVs, 2 gray tubings, 2 green, 2 lavender, and 2 gold. We have 2 vacutainers to obtain blood cultures, a blue IV clave. We keep a sheet inside every kit so that it has the inventory, and then when something's used, they just list the quantity used so it can easily be replenished. 2 IV start kits to start IVs. 2 tourniquets, 2 IV extension sets, specimen bags to send all the lab work in, 2 22 gauge angiocaths and 2 24 gauge angiocaths to start IVs, 2 iodine swabs, 1 for each site to obtain blood cultures. We have a box of Band-Aids, a box of alcohol swabs, a box of 2x2 gauze, tape, and 2 butterfly needles to obtain the blood cultures, and then we have 2 anaerobic and 2 aerobic blood culture tubes.
Recognizing early signs of infection is key. Some of the early signs that even a family member could notice would be confusion or disorientation, shortness of breath, high heart rate, high respirations, fever, cold, clammy skin, extreme pain or discomfort. The screening criteria is they would need to have symptoms such as fever of greater than 101.5 or a high white count on the CBC of greater than 12,000. Once the complete blood count is drawn, if they have a white count of greater than 12,000, we initiate the protocol. If they have a fever greater than 101.5, we also initiate the protocol. We'll do blood cultures times 2 sets, anaerobic and aerobic, from 2 separate sites. We utilize this sepsis kit in order to gain those lab works. Also, we may start an IV for IV fluids, as well as initiate an antibiotic. Once the blood cultures are drawn, it takes 48 hours for anything to grow. So in the meantime, we start, if they've had a previous infection, the antibiotic that they were previously on. If they did not have any recent infection in the last 6 months, we would start them on vancomycin and meropenem. The infectious disease doctor will be consulted as soon as we get the blood culture results.
The sepsis protocol is initiated when the white blood cell count is higher than 12 or a temperature of 101.5. If they have one criteria, then we would obtain a urine culture and a chest x-ray, and a CBC and a CMP would be ordered for the next day. In the meantime, we would be checking vital signs every 4 hours to monitor for a change in condition. When a resident meets 2 of the criteria, we would start the resident on IV fluids and the IV antibiotic as ordered by the doctor. We would obtain the blood cultures before starting the antibiotics. You would also still obtain the urine and the chest x-ray. CBC and CMP can be drawn in the morning, but we usually obtain them ourselves at night. A hospital transfer is indicated when the resident meets 3 criteria as listed on the sepsis pathway sheet. 3 of the criteria would be a white blood cell over 12, a temperature of 101.5 or higher, a heart rate of 110 or higher, or a respiratory rate of 25 or higher.
If the resident meets all 3 criteria and they have a mean arterial pressure of less than 65, they are immediately transferred to the hospital. We continuously monitor the resident every 4 hours for vital signs, and we're at the bedside frequently. A successful case would be where the resident bounces back, may not be febrile anymore, and responds well to the IV antibiotics. The minute there's a change in status, the family is notified. They have the option to have the resident transferred to the hospital. It is important that the education is done and their advance directives and their care planning is managed. We sent out a letter indicating all the initiatives Carmel Richmond currently has, including the antibiotic stewardship, palliative care, as well as some of the sepsis protocol initiatives. The families have been educated upon admission, as well as ongoing education is available.
From reviewing the hospital data, we found out about 25% of our patients actually was admitted to the hospital with sepsis. We're thinking of a way to see we can improve the outcome by initiating the treatment earlier, because time is of the essence in taking care of this type of patient.
We make sure that the IV certification training is done with our nurses, and that all of the nurses are up to speed with the latest and the newest innovations we're doing with the sepsis protocol, so that they are comfortable, and we have a lot of support with the NPs and the other nurses and the administrative staff.
We also use a vendor service to put PICC lines in and midline catheters for patients who need extensive antibiotic or IV hydration. So if we have difficulty with just a peripheral line, we can call this service in, and they come in very quickly within 4 hours and place the line. So that's a very important piece of the management of the sepsis protocol. So as part of our quality improvement plan, every hospital transfer, regardless of whether it results in a hospitalization, it could just be an ER visit, is reviewed by Dr. Howe. There's a retrospective review to ensure that all our protocols have been put in place, and to check to see whether this was an avoidable hospitalization or not. And we do use the Interact summary hospitalization review tool for that. We also put all of that information together. We do a summary, a monthly summary. We have a rehospitalization meeting weekly where we review every hospitalization that occurred in the last week, and then also identify any patients who are very high risk residents that also have had frequent hospitalizations that may benefit from palliative care program. So then we identify those folks and we move ahead with that. We use the DSRIP data for admission diagnosis code that we submit on a quarterly basis to review all the admission diagnosis codes to see if we are improving in the sepsis protocol process. And we've been tracking all of those as well. We also, with the sepsis protocol, we have an audit tool so that we're ensuring that all the staff is completing the protocol properly, and then if we find any problems with that, then we have in-service education to ensure that that area is addressed. Physicians are all on board with the sepsis protocol. It pretty much mirrors the hospital protocol, so they're very comfortable with that process. So we continually audit the data. One of the things we will be tracking is based on the DSRIP admission diagnosis codes that we receive from the two hospitals. Anybody who was admitted with a diagnosis of sepsis, we will go back to see that the sepsis protocol, to see if the sepsis protocol was initiated prior to them going out to the hospital. So that will be an important piece to identify anybody that we missed and why we missed them.
So as Director of Nursing, we'd like to know that our residents are being cared for to the best that we can. And the sepsis protocol allows us to go a little bit beyond so that our families are comforted with the IV and the sepsis protocol as we know it, with training with our nurses, making sure that we have respiratory and the support that we need with the lab, the hospital, and the collaboration for all the other disciplines that are needed in order for the residents to feel that they're comforted and they're able to get the care that they need here before going to a hospital setting.